Welcome everybody to the meetup. I'm going to let us get underway here. We have myself, Art Caplan, as the host and moderator, although I'll be a little active myself. I'm currently at NYU, the Division of Medical Ethics. I'm talking to you today from Ridgefield, Connecticut, where I live, where the temperature tonight will probably be about 6 degrees Fahrenheit, freezing beyond belief. I feel like I could be at brochure and warm up if I was lucky. Anyway, we were just talking American politics, which we could spend an hour doing, but it's better by my lights. So thank goodness for some changes. And we have a great group to get us underway. I've asked each of them to introduce themselves, say a little about their work, and then talk for a few minutes about COVID and how they have interacted with that either in their own work or watching what bioethics has done around the world in trying to engage questions, ethical questions at the bedside or policy-wise about COVID. Then I'll ask each of them some questions, and then we'll go to the chat box. And if you want to ask a question, please put it in the chat box. I'm looking at that. I see greetings coming in pretty quickly already in the chat box, but questions can be asked at any time. I will go to them. We want to make this very, very interactive. So no particular order here, but I'm going to start with Yang and then go down the way I see folks on my Zoom screen. So the floor is yours.
Thank you, Arthur, and thank you all for, and first of all, of course, thanks the Broach Foundation for giving me this opportunity to join this discussion on COVID and bioethics. I am not currently working on COVID-19 myself, but as someone who is living through this pandemic, as everyone here, I have been observing the unfoldment of the pandemic and very interested in how bioethics have been contributing to the discussion and policy making in different countries. Well, I thought we are going to prepare some kind of formal opening up. So I did look into how the bioethics in China had been contributing to the discussion, which is less visible as compared to what you have done, like Arthur, in America, especially on the human challenge trial. I'm sure we are going to talk about it later. But what is less visible doesn't mean the bioethicists have not done much in China. Actually, they have been very active in helping the hospital directors and local and central governments in formulating policies, but in other formats rather than, for instance, journal articles or giving interviews to journalists. So I think when we're talking about the contribution of bioethicists to COVID-19, we should be in mind this can vary among countries. So I would like us to really think about as a discipline, and as we would like to consider ourselves as bioethicists or not, how we can and put our resources together and really address the challenge at the global level. I think one of the critical questions here is the politicalization of COVID-19 and the pandemic, and we can see how nations have been drawing apart. So I think it is critical for us to think about how we can help to heal the divisions. To some degree, the scientists have done so through their joint work and pulling resources together, organizing in different ways, and public-private partnership, collaboration with citizens and also pharmaceutical companies to make the vaccine available. It's quite a miracle. But I think as someone or as us think about we can contribute to make science better and the world more just, I think we should not shy away from the daunting task of how to heal our divided world and make the world a better place for all. So that's all. Oh, yes, my current work, I'm now working at the Institute of Zoology, Chinese Academy of Sciences. And my focus now is on biotechnology, especially stem cells, regenerative medicine, and how that played out in different contexts. So briefly, that's all. Thank you very much for your attention. I look forward to the discussion.
Thank you. Thomas?
Thanks very much. Thanks for involving me in this this panel. So I'm Tom Douglas. I'm based at the UHERO Centre for Practical Ethics in Oxford in the UK. I work mostly at the moment on the ethics of behavioural influence, like via things like nudging or persuasive online technologies. But I've been doing a little bit of work on COVID as well, partly because I had been thinking about some relevant issues in criminal justice ethics before the pandemic came along. So I was thinking about how we should balance constraining people's freedom of movement and association, as when we lock people up in prison, against, for example, requiring people to undergo medical interventions like methadone treatment or chemical castration in a criminal justice context. Then turns out that there's a similar comparison to be made when thinking about how we should balance or compare quarantine, isolation, lockdown constraints, which constrain people's freedom of movement, and things like compulsory vaccination or treatment, which might be considered at some point. But I thought I'd again just give some very brief comments on the kind of debate about COVID here, especially in the UK, and I guess especially focusing on the kinds of, I guess, the more philosophical end of bioethics where I work and what bioethicists have done well and badly. So, and I'm interested to hear what others think. So one thing I think bioethicists have done quite well in the debate here is to make explicit the kind of value judgments and trade-offs that underlie policy decisions, which the government here has been very keen to avoid. So the government here is always saying we're just following the science whenever they introduce a policy or whenever they backtrack on a previous policy. And they never sort of acknowledge that there are value judgments to be made about what aims we should actually be pursuing, how we should balance economic and health effects, for example, or what sort of absolute ethical constraints there might be on things that we could do to people in the context of fighting a pandemic. And I think bioethicists have been really good at kind of putting those value judgments on the radar. Another thing I think ethicists have done quite well, I think, is sort of drawing analogies to more familiar areas of policy. So just to give one example, here at the moment, there's quite a lot of interest in vaccine passports. So requiring people to prove that they've been vaccinated, and then with the idea that they might be able to be released from some of the kinds of lockdown constraints that are being imposed on other people. And most of the debate amongst policymakers and sort of journalists seems to sort of assume that this is an entirely new kind of question that we've never considered before. But I think bioethicists have been quite good at pointing out, well, this is, quite analogous to other things that we already do, like, requiring people with epilepsy to prove that their condition is being well treated before allowing them to drive a car, for example. So I think that's another area. I guess it's unsurprising that ethicists have been good at that, since a lot of our work is often about drawing analogies. But that's one way in which I think ethicists have contributed well to policy debate. And then one thing that I think that maybe ethicists, at least in my kind of corner of bioethics, haven't done so well is actually kind of get their substantive recommendations to have any influence on policy. And I wonder if one reason for that might be, I guess there are lots of factors, but one reason might be that we're often not kind of strategic enough in the way in which we present and time our information, don't maybe take into account the kinds of political considerations and the social mood. I think there's a tendency, maybe in ethicists, certainly I'm guilty of this, of kind of the way in which we try to influence policy is by spinning off whatever our most recent publication or argument is into some piece of policy advice, when it might be something that the government's not interested in, or is regarded as kind of politically unfeasible because it would be so unpopular. So that's something I think that maybe we should think about doing more. I could give plenty of examples from my own work of where that's been a problem, but I'll stop there and let someone else have a go.
Thank you. Very useful. Jan Helge.
Thank you, Art. I'm professor in medical ethics at the Center for Medical Ethics at the University of Oslo. I have just a few months ago co-written a huge paper on the current situation with the main title, Back to What? ? We have just succeeded in getting 3 big EU-funded projects. 2 of them are science with and for society projects, but nothing to do with COVID, one on the ethics of organoids and the other on open science. But the third is entitled Access Africa, and it relates to the issue of post-trial access to the benefits of trials. I want to focus on 5 concepts, and I will shoot from my hip. The first is pandemic, which comes from 2 ancient Greek words, pan and demos, which means all people. So why do we not consider this situation a situation affecting all people, all inhabitants of the global village? I will come back to that. The second concept is exceptionalism. Some very prominent bioethicists have insisted that we are living in exceptional times. And for this reason, we need an exceptional ethics. And the main message so far in the current situation is that we need to cut corners. We need to find other rules of play than the present rules of play, because we need results as soon as possible, as fast as possible. I think this is a dangerous argument for 2 reasons. First, this is not an exceptional situation if we look at the history of humankind. This is one of hundreds of pandemics that have been affecting this planet. So if we should think in exceptional times, then maybe we should think also the ethical responsibility in a completely different way. That brings me to the third concept, nationalism. What we see now is a horrible form of vaccine nationalism, where the richest countries in the world already have contracted or bought up most of the vaccines that will be available for the next 2 years. We are talking about a pandemic. We are talking about a disease that will affect all citizens on this planet in different ways. And in spite of that, and in spite of an existing consensus that the most vulnerable groups should get access to the vaccine first, it's only the vulnerable groups in the richest countries that get this access, not the vulnerable groups in sub-Saharan Africa, in the poor countries in Asia, in the poor countries in Latin America. Now we are talking about the danger of the virus mutating. And from an epidemiological point of view, we know that the longer time it takes to fight this pandemic, the higher is the risk of new mutants coming, and they will come from these poor countries which do not get access to the vaccine. I read yesterday 45 countries in the world still haven't got one vaccine, while a country like Canada, the European Union, Norway, and the United States of America, they have contracted a size of vaccines that will provide not just double doses to the population, but several times. This is, for me as a bioethicist, it's a shame. And it's a shame that so few bioethicists haven't raised this question. That brings me to the last concept, servility. Also, bioethicists want to have impact and influence, but very, very few bioethicists in this period have spoken truth to power. Many bioethicists have provided arguments to the most powerful players so that they can get what they want. And if we are going to talk about or take the consequences of living in exceptional times, we should take into account two things. First, the core principles in research and also in clinical practice were carved out in the aftermath of a horrible catastrophe that was even bigger than this catastrophe, namely the Second World War. And we should stick to these principles. For example, the priority of the individual principle. Second, if we need to do some kind of research in this context that is dangerous, well, Article 5 or Principle 5 in the Nuremberg Code said, in such situation, the only possible justification for such research would be if the most informed citizens of the global village were enrolled in this, and that are the researchers themselves. Second, if we want to develop an exceptional ethics, we should move away from what I would call trickle-down ethics, which is now the most prevalent kind of ethics also in this period. And we should try to develop an ethics that really take seriously this situation is affecting all inhabitants of the global village. And for this reason, we should prioritize accordingly when it comes to access.
Thank you. We'll have much to discuss there. Kirish.
Thank you. Okay, I am Kirish Aramesh, and right now I am a faculty member and director of Bioethics Institute at Edinburgh University in Pennsylvania. Before that, I was a faculty member at Tehran University of Medical Science in Iran. My current work is focused on science, pseudoscience debate, and it is related to the pandemic because we have seen a surge of pseudoscientific claims and science denialism and anti-scientific claims during the pandemic. So I know that it's not the most important bioethical issue about the pandemic. The most important ones are, that's a beautiful dog. The most
In your remarks.
the most important topics are centered around distributive justice, how have access to scarce resources of treatment, now distribution of the vaccine. So those are the most important issues, but my work was focused on another issue that's not much less important. And during the pandemic, we saw the surge in pseudoscientific claims all over the world. And another phenomenon we observed was political endorsement and political promotion of pseudoscientific claims. So I think part of the job of bioethics, as John Helch said, is speaking truth to the power. Speaking truth to the power when political powers endorse and promote pseudoscience, endorse anti-scientific ideas, and endorse science denialism, the pattern that we observed in United States and other countries like China, Iran, and Brazil. I think there were no country without any evidence of any pattern of biopolitically promoted pseudoscience. And that's what I think we can call biopolitics, a version of biopolitics, political powers supporting and promoting something in health sciences that have raised ethical concerns. So there are many examples. For example, in some countries, promoting local branches of so-called alternative medicine raise concerns about approving medications that are not really effective or tested based on evidence-based medicine, or including those medications or theories in research trials without observing all the related ethical standards. So I think that bioethics can address the issue in different domains. For example, in the field of research ethics, the values of scientific validity and social and clinical value should be observed by IRBs through a bioethical perspective. In clinical ethics, actually, objective Hippocratic utility that includes evidence-based medicine, the ideas or values of evidence-based medicine need to be explained and also supported and promoted by bioethicists. Otherwise, non-evidence-based claims will expand and endanger the life of people, and that will be an embodiment of maleficence in the realm of biomedicine. And in education ethics, and both education ethics and ethics education, an important issue is considering scientific literacy to be taught to both clinicians and people who use medications or enroll in research studies. So that's the topic of my work right now. I've published a few papers in this regard in the past few months, and right now I continue working on this topic. Thank you.
Thank you. I'm just going to say a word about my own role. So I've been active in the pandemic in a couple of areas, and it was partly because we had established at NYU when I came here 8 years ago, a project on vaccines and ethics. And we were looking at those issues with flu, with cholera, with Zika, with many, many different types of vaccines, both issues around vaccination in wealthy countries, refusal rates, uncertainty about safety of vaccines, anti-vaccine sentiments, distribution of vaccines. As Jan Helge said, I think it's not so exceptional. We had some pretty heated debates about who was going to get a swine flu vaccine back in the day, and a lot of policies were made and jousting to get access both between nations and within nations. So in that sense, we were well prepared to engage the vaccine issues in particular, and that's a place that I've been very active in terms of engaging the US government, state officials in the US, and talking sometimes to a company like Moderna, not for pay, but just when they ask about issues of distribution and questions that they have. And it's been interesting to see how that goes. So I feel like I've had a lot of opportunity to interact there. The other thing we had a project on, again, just happened to do it, was pre-approval access to drugs and vaccines before regulatory agencies had approved them. We've had an 8-year project. I work on that with Allison Bateman House. We were looking at issues of compassionate use, expanded access, emergency use authorization, long before COVID. So when these issues arose, we felt very well positioned and ability to speak out and say what we thought was important in the spirit of what Kierish said. For example, we were strong proponents of using expanded access in the US to grant early approval to vaccines, not emergency use authorization, because expanded access gave you better science, gave you better consent, and was a more organized approach to the distribution of an unapproved agent. We just didn't win that argument, but we tried, we argued, we spoke up, we wrote, And so sometimes we've tried to influence, didn't always succeed necessarily. A lot of papers came out too on issues like, I've been thinking about challenge studies long before COVID. So we got into the ethics of what had been done in the past with that, and is there ever a situation where we could use it? Again, to comment on Helga, not so much out of exceptionalism, but basically saying we've tried this in other contexts. When did it seem appropriate? Would it be appropriate here? Who? Maybe the researchers first, as was said, and so on. So that's been a sub area which has led to influence. Weirdly, Thomas, more the British have been attentive to our arguments here pro challenge studies than the NIH, where we've had less success, or other nations, in being persuasive. So I point out, sometimes you make your points, you don't win, you sort of say what you have to say, and it's part of the role to move on. Obviously, I get an opportunity to communicate about issues in the media, just having a history of that. Try to do that, listen to feedback about the success or the accuracy of messaging. I certainly have been big on trying to debunk pseudoscience. I will say that. I'm not in the camp that likes to see non-evidence. When our president said we should all drink bleach, that gave me at least a couple of days to comment on why that probably wasn't evidence-based advice. And it's been interesting. I'll just wrap up. I have a lot to say in this, but I'll wrap up with two other comments. I was with an administration prior where I did not have contacts, was known to be a critic just politically, and was more of an outsider. And so the bioethics role, if you will, in speaking truth to power, yes, but not if they don't listen, which was a problem, because COVID was not mentioned by the President Trump in the last 3 months of his administration. Since I think it's the most important problem facing the world, if we're going to get jobs back and schools open and return to travel and stop killing people, that would make it pretty high up on the policy list, but it wasn't. And so there has been an issue about who do you talk to? If your government isn't always listening, do you go to local officials? Do you try to talk to scientists, professional societies? And I'll just put that out there as an issue to think about. And the last thing I'll say is I thought, in general, one failure of bioethics, I'm not so sure we're going to get into the global versus national issue. I'm not sure that has been so much a failure. I've been a little bit more of a defender of a modest nationalism to take care of local needs before we worry about global needs, but we can argue that. What I have been disappointed in was I think bioethicists were too interested in arguing the moral priorities of access. What I learned is that logistics, practical distribution drives access. So if you have to get on the internet to make an appointment, if you're 80 years old, you don't have a fair chance. If the distribution of vaccines is only available in certain places and you have to drive there or travel, then poor people or people who work and don't have daycare and help aren't going to get there. Doesn't matter what the list says. If you're in a situation where you don't have a policy about what to do if you have excess vaccine because people turned it down or didn't come to your appointments, then you see the people in charge of vaccination just scramble to decide what to do because they don't want to throw it away. And it leads to undercutting of the priority rules because they're just giving it to anybody. I think bioethics, in my opinion, failed to anticipate the importance of logistical, practical distribution on this kind of a resource. And I blame myself a little bit because I'd worked on vaccines and I understand some of these practicalities, but I didn't incorporate them into my own, I'll just say, into my own thinking sufficiently. And it has led to a very bad distribution just in the US because the logistics have really undercut priority listing. It's not that we don't have priorities. We all know what they are. We all agreed, elderly people, nursing home people, even prisoners, even people in group homes with intellectual disability. It hasn't mattered. If the vaccines don't show up where they are, it doesn't really matter what the list is. So that's been a lesson for me, that a little bitter lesson, but And I consider it, as I said, a little personal failure, because I should have known better. The audience here is chiming in with questions, and I'm watching the time, and I was going to ask each of you a follow-up question, but I'm not going to do that because there's too many questions from our participants. So let's see if we can get them involved as I open up the chat box a little bit. I got lots of people raising questions. So here comes the first one. I'll ask the question. Eka is asking, the values of evidence-based medicine are not obvious. What he means is, in one sense, it's trivial that decisions have to be backed up by good evidence. On the other hand, science could be morally blind. You can't necessarily derive an ought from an is. Is evidence-based medicine just a buzzword? Are we really overvaluing it as something that policy turns to or really drives clinician behavior? I'll go back to Kiarish on that one, since I know you started there. So is this just some kind of a prop that we hang on to, believing in evidence-based medicine?
Actually, evidence-based medicine is neither a buzzword nor the science is value-free. That's correct that we cannot derive values from scientific facts, but it doesn't mean that there is no values observing or regulating or overseeing science. In addition, here we don't talk about science itself. We talk about we are talking about policy making and governance. So in the realm of policy making, how we can choose certain interventions and avoid choosing others, other than relying on evidences and evidence-based medicine. Otherwise, all the claims will be equal. So talking about evidence-based medicine and its shortcomings and its failure, theoretically speaking, is one thing, but in practice, we don't have anything better or even comparable with evidence medicine to use in addressing or evaluating the efficacy and safety of new medications. So because of that, I think we are ethically obliged to keep using evidence medicine in evaluating the effectiveness and safety of any new suggested intervention from any sources they would come. That's my short answer.
Thank you.
Thanks.
So I've got one for you, Thomas. This is from Peggy Batten. She's asking, and I'm asking you because I know you work in the nudge and modification of behavior area. How do we balance protection of freedom of speech with the damaging effects of militant vaccine denial? That is, not merely denying a vaccine that you don't want to take it, but persuading others to refuse it. So there are many people who see it as their mission on social media or in other contexts to try and get people not to vaccinate, to distrust vaccines. We want to respect their right to say that, or we don't. Should we take them off Facebook and say you can't speak there anymore? I think some of you know our recent president has been disappeared from Facebook. Is that the right approach to take in respecting people's right to say what they want? Or are there other ways to change their behavior is what I'm getting at, if you want to promote vaccines?
Yeah, I don't know if I have an interesting answer to where to draw the line on when freedom of speech would be justified. So, but I guess there's a lot we could do beyond that. So, I mean, if you think of, how do we respond to people who deny that there's climate change or something? We generally don't kind of try and shut them up. We just try to make clear what the kind of dominant scientific position is by kind of having the scientific community organize themselves to get their act together and actually come up with sort of a kind of joint statement on what the actual scientific consensus is. And it does seem to me that COVID has kind of created, the kind of bioethical response to COVID has been in some ways, I think, kind of positive in the sense that it shows that there's a lot of diversity of opinion amongst bioethicists and people give different views, and lots of bioethicists would disagree about lots of the foundational debates. But it's also a kind of been a rare example of where there's actually a sort of urgent need for bioethical input and a need for sort of maybe bioethicists to come together and come to consensus on certain things. And there are probably lots of things that bioethicists could agree on, like that what the values of vaccination are, that we could have kind of done better at kind of solving the collective action problem and forming some kind of consensus statement on what does the bioethical community think about this. And similarly, I mean, I'm sure the issue about ensuring better vaccine access in low to middle income countries is also something that pretty much all bioethicists would agree on as something that's being neglected and not dealt with properly. But because bioethicists have just been kind of mostly responding as kind of individuals pursuing their own different opinions, there hasn't been a very kind of powerful joint voice, I think, which seems to me to be a problem.
I've got one that I'll give to Yang and Jan Helge. Yang maybe answer this first, then I'll let Jan Helge follow it. This is on the issue of bioethicists and their role as decision makers from Robert. He says, ethicists have been involved in policy development in developing guidelines, say for critical care, who gets a ventilator, triage, that sort of thing in some contexts, prioritizing who gets a vaccine. He's talking from a Canadian context. Is that basically using the ethicists to do what politicians want to do? Are we just cover? Or do you feel that we've been able to challenge and shake up what I'm adding to the question here, but to in a sense, go beyond just approving what the politicians say they want to do? And
Well,
you get that first.
This is a tough one, but this is also something I've been thinking about for a long time. I think bioethics have been questioned about our role, kind of at the arm's length towards policy making. But as Arthur, you mentioned that sometimes we fail when no one listened to us. But from my perspective, it's not a simple question of being used, or we are applying what we know and contribute our expertise in solving the problem. This is something we need to figure out in practice. But I think, just responding to what has been discussed here, there is a danger for us to publicly disagree with one another and use our analytical and critical skills as compared to science. I think one critical lesson from science communication is that sometimes we need a clear message to the public. Well, I think as bioethicists, we tend to disagree with one another, and we tend to fight publicly. I'm not so sure that is a good idea in certain contexts, whether or not we are speaking to power or we're trying to get our message across to the general public. And I think we need to also be careful of using the words such as pseudoscience or evidence, because the field is developing so rapidly. Scientists do not know what exactly we are chasing after. So what is pseudoscience? What is science is precisely the question. I think it often we feel righteous of claiming that we are on the right side, on the moral side, and forgetting that we should put people first. Those are suffering, those people on the street. And I think there's a danger if we just talking among ourselves and feeling good about what we are discussing. We tend to become those elites who sometimes we refer others as. And we have seen that played out in politics. So coming back to what I would like us to think about is how we can to really heal the division in our world. I think that is something, if we like to speak to power or just to the people on the street. I think that is something worth our efforts. So thank you.
And Helga, are we speaking truth to power, or are we just lapdogs sort of taking our pay and letting the powerful get a blessing?
Let me suggest 4 different roles we could take on. I have always been skeptical to bioethicists being decision makers. For example, beeper bioethics, I am not confident with having that kind of role. But there are 3 other roles possible to consider. One way is it was suggested by Matti Heiri in Finland. He labeled the bioethicist as some kind of polite bystander. Maybe that is too polite, at least for me. A third role characteristic comes from Bernard Williams. Maybe bioethicists could act as informed helpers. But I think the role that I like best is the comic figure. I have a passion for the ancient Greek theater. Why? The comic figure or comedies are daring to speak about the unspeakable things in life in the open, and they are listened to. And I think what is needed is for bioethics, also in this pandemic, to address the taboos, those issues that are silently neglected or overlooked. There has been a lot of focus on vaccines. There have been a lot of focus on these human challenge studies. There has been lately some focus on all the enormous logistical challenges that Art also referred to. But there is almost no focus on the fact that the richest countries in the world already have robbed the rest of the world for some of the benefits all inhabitants of the global city should get access to. So I feel most, what do you say? I feel closest to the role of a comic figure.
Well, the fool has always got a lot of wise things to say in Shakespeare. On the other hand, if you take my idol Socrates and you go out in the public square, eventually if you mouth off enough, they poison you. So there's danger sometimes in those roles, but I appreciate both of those bits of feedback. And now we have to go, I must say, to the issue that keeps popping up here about global distribution, international distribution of all resources, whether they're vaccines or tests or antibodies or wisdom about behavior modification, whatever it is. Many people, Len Fleck, Ruth Macklin, I see here, many are asking a very practical question. Yes, it may be true that we should worry about global distribution. And as Jan Helge has said a number of times, many nations, Canada, I think, bought 9 times the supply of vaccine that they could use in the whole country. Who's in charge of this distribution? Who is it that we're talking to try and achieve perhaps more equity in distribution of resources is one question that many are asking. And then another is, are there, if you will, voices that we should be adding to the bioethics debate, sort of in the way that Yang suggested, that would help press the issue of international equity and justice and thinking about how that should work more? And I'm going to throw that question to anybody who wants to comment. Anyone? Yep, Jan.
Well, for more than 70 years, we have had the United Nations system. It is not a perfect system. It is a system that works slowly, but it has prevailed for more than 70 years. And what have we seen during the last 15 to 20 years? That the member states of the United Nations, they have outsourced more and more of the resources that were channeled into the United Nations system to so-called private-public partnerships, which means, for example, WHO, some of these big players have more influence in WHO than the member states. So I think what we need is to boost up the United Nations system, which is not perfect, but it is a system that has a global perspective. It is a system with representation from every country in the world. And I think there is no better system than that, although this system is not perfect.
And what about the issue, I'll just repeat it, of more voices, more input? Yang, do you think that, or anyone, Kiresh, anyone who wants to comment here, is bioethics dialogue dominated by Western bioethicists and therefore reflecting their interests, or at least where they pay attention? I spend all my days arguing about vaccine allocation in the United States. That's not going to help anybody anywhere else if that's the sole voice that sort of gets heard on an issue like that. How do we, is it partly to enrich the dialogue somehow?
So may I just first quickly respond to the vaccine allocation? I think bioethics and public health researchers have been actually attended to this question, and WHO has been working on that. So I just sent the link in our chat box. And I think for our brochure meetup, actually in the first session, this question has been discussed. So anyone who are interested in maybe checking back, and I know that in our next session, the brochure meetup is going to address this question also. So I think this is for sure a critical question. And I'm pleased to say that bioethics are not behind, and a lot of people are working on this question. But I would also like to quickly address about what Arthur, you asked me about the diverse views. I think it is critical for us to learn from the experiences from so-called low and middle income countries, because epidemics have for long hit the most vulnerable the hardest, which is Africa and Asia. But in previous discussion about biosecurity, those countries and regions are framed as the others, so the biopolitics of the others. So we think, or people in America and Europe think, that is their problem, and we just keep them at the border and we'll be fine. But this pandemic at the global level show exactly the opposite. We cannot stop the virus and we need to live with them. So I think the opposite now is true, that we have to learn from the lessons that and the wisdom and the skills have been learned in regions like Africa, like South Asia. And sometimes it's not because of ideology or differences in political systems. It's simply because it works. Mask wearing works. So sometimes we should not be blinded by politics, and we should not be blaming everything for politics. And if we want to make the world better, we have to find our way to address the question rather than scapegoating everything about politics. That is just, for me, that is kind of intellectual laziness. That's all. Thanks.
Yeah, Kirish.
I just would like add one point, is that's talking about or having concerns about dominance of Western bioethics. I think it's somehow confusing because the values that govern bioethical discourse, including about distributive justice and what was talked about in this panel, are part of a common heritage of mankind, not Western values. So justice or distributive justice and other values of many of other values of bioethics are not Western values, are common heritage of mankind, including human dignity and others. But I think the best way to include voices from other countries is promoting multilateralism. That, for example, empowering World Health Organization as a tool, as an organization to promote multilateralism in the field of health, public health, and bioethics. Thank you.
Yes, Tom.
Just very briefly on this issue of international organizations and the UN. I mean, I agree very much with what Kiarash and Jan Helge were saying about, we should be using international mechanisms a lot more than we are. But I kind of wonder if, given the kind of urgency and the fact that those institutions just don't have a lot of leverage over the most rich governments, really the best kind of pragmatic approach that we should be taking is lobbying our own governments, those of us who are in rich countries, to do more, to take it upon themselves to provide vaccines to other countries. I mean, there are some governments of Western countries, of richer countries, that have been trying to do that. The government of New Zealand has been trying to buy vaccines to cover Pacific Islands as well as their own population. There's no reason why more governments couldn't be doing that, and seems to me a kind of more realistic way of, in the short term, trying to get as many vaccines as possible to the countries that are currently missing out altogether.
All right, thank you. I've got one quick question that's aimed at me about how do we deal better with the press, moving them on from just wanting to tell horror stories about individuals cheating to get access to something. And I'll say two things on that. One is, I think it is always possible when a journalist contacts you or reaches out to you to suggest a different angle on a story. So they come with a question, but you're the expert. So if you don't think they're attending to the right issue, you can suggest another or suggest a story idea to them in the future. That is part of what it is, good interaction with media. And then take things into your own hands. I spend a lot of my time talking to the audience that Ye Yang was referencing, trying to reach out to people through op-eds or communications and newsletters. It doesn't always have to be the big media talking to politicians. You can talk to patient groups. You can talk to many other groups if you hit their newsletters or their social media. And that's a way to establish your voice about what you think are important issues and build allies, like the patient groups who will then join you or echo or at least engage the debate. So that's a fast answer there. All right, I'm alert to the time, so I'm going to sadly close down the questions from our many participants. Thank you for those. I'm going to let each person here on the panel have a final word before we end the session today, which has been great. I want to thank everybody for doing it. Before we do that, so last word, you don't have to take it, but if you want to take it, Thomas, I'll start with you.
I don't think I have any great brainwaves. I guess one thing I wanted to say to, there's been a lot of, in a way, negativity about the failure of bioethics to have more influence, which I think is justified, but maybe we shouldn't be too hard on ourselves. We can't solve all the world's problems ourselves. And I think that we shouldn't forget about some of the kind of more modest contributions that we can make. I mean, one thing that a lot of bioethicists are good at is kind of seeing bad arguments and calling them out. And I think that, and doing the kind of thing that we would do when teaching undergrads on critical thinking classes, for those of us that do that kind of thing. And I think that, one thing that we can do is to try to improve the quality of public debate in very small ways, just by calling out fallacies and bad arguments when we see them, and bringing, making implicit premises explicit, and doing all these kinds of things that that kind of make for a more rigorous public discussion. Thanks.
Yang?
I really would like to see our discussion continue in one way or another. And I think Broach Foundation is really a unique platform that draws different minds together. And I think we should put not only our mind, but also our heart, our hands, and even our stomach in this fight and create a better world for us all, and also the other beings and the planet. Thanks.
And Kirish?
No comments. I would like to thank the Brochure Foundation and you and all the panelists for this great discussion. And I hope all these efforts will be continuing and we will have a more ethical world in the future.
Yeah, and Helga?
I would point to a challenge ahead where bioethicists could do a good job. Article 14 of the Universal Declaration on Bioethics and Human Rights, the only universal normative framework in bioethics that can aspire to be universal because it has been adopted by all member states of the United Nations. This article is on benefit sharing, where it states that the fruits of scientific and technological development should be shared with the society at large, and in particular with developing countries. And here, bioethicists could join forces, collaborate together and say, what would that entail in practice? How would a pandemic ethics look like? That is an ethics targeting all inhabitants of the global village when it comes to accessing the benefits of scientific and technological development. And thanks to the fantastic Fondation Brochure.
So I'm going to end with an example of a little victory that Tom was citing. We had a big discussion at my own institution. I realized when the pandemic first broke out and it hit New York very hard, and the hospitals here, that people were dying alone. And they were isolating them and they wouldn't let anybody in the rooms. And we didn't even have phones or iPads. And I got asked by some patients, why can't they go in the room if they wear protective gear and if they're willing to take the risk? And I raised this issue with our hospital, our policy, and we changed it. And so nobody dies alone, because we felt the moral thing to do is to not let you die alone. And the moral thing to do is to let people be protected, but assume certain risks. Now, we don't have to go crazy. We don't have 10 people in the room, but we do have somebody with the ability, and I'm trying to extend that to nursing homes as well, where the same problem was coming up. It was a small change, maybe a little victory, but it has meant a lot to me, because I think it really improved in a practical way the dignity of people dying and families grieving. So it's not bioethics on Helga, but it was a sort of policy shift that I think improved something that we could weigh in on and help work with palliative care in nursing to fix, and chaplains actually too. All right, well, I want to thank the foundation too. I think Anik is telling me that the chat box will stay open a few more minutes if you want to talk to one another via that medium. I'm not sure whether we can stay on a little bit more in terms of the actual Zoom connection. I'm going to have to leave myself, and I'm not asking any of the panelists to stay. You're welcome to do that if you can. But this was really wonderful. I appreciate everybody taking the time to do it. We had a really great turnout. I hope the future ones are as successful. I hope it gave Brochure some ideas of themes and topics they might explore. Maybe there's even some opportunities here for more collaborative work amongst our Brochure alumni down the road. I'll give you an example of something I'm trying to gin up interest in. I know something is coming that we should all pay attention to, and that is the exploitation of clinical trials of vaccines and medicines to poor countries. Once the rich countries have them, it's going to be hard to enroll people in studies there. And I know what's going to come up. It's going to be, let's go to the poor. You told us to do something for lower and middle. Here it is. We're going to give you research. Good thing, bad thing. How do we govern it? How do we handle it? Absolutely coming down the road for those who are worrying about evolving issues. So there's one that I think we should get ready to argue about and debate. Again, thanks to all. I'm not sure when the next one of these is, but I'm sure Anik will post it. I think we've got some more coming. And thanks to Brochure for being there and doing all you do.
Thanks, Arthur, for chairing.